Hello everyone, hope you all are doing good. So I've been planning to make this video since a long time now and been very busy lately. So let's start with another day with me session. So starting with the first case of the day, so here we have a 40-year-old female with chronic cough who has recently completed her course of ATT. She was started on ATT 1 year back based on the findings on CCT, and now she has come for a follow-up scan after completing her course, and we got a CCT done for this patient. This is the plain section, axial section, mediastinal window, where we can see a cavitating lesion in the right upper lobe of the lung. Few other cavities are also seen within this consolidation, along with some enlarged nodes in the mediastinum. Let's see the lung window. So here we can see multiple nodules that are seen in the right upper lobe, along with some ground glass opacities and interlobular septal thickening, and this cavity, large cavity in the right upper lobe with air fluid level. So this is the coronal section, lung window, where again we can see some air crescent along with multiple soft tissue density nodules in the right upper lobe of the lung. Let's have a better look of this lesion in the post-contrast sections. So this is the post-contrast mediastinal window axial section, where again we can see this cavitating lesion along with some air and multiple other cavities that are seen within this consolidation in the right upper lobe. There are multiple enlarged lymph nodes in the mediastinum as well. And in the lung window, again, we can see this ground glass opacities, this air. So basically, it's a cavitating consolidation that is seen in the right upper lobe, along with multiple soft tissue density nodules, ground glass opacities, pointing towards an infective etiology. So this is the report that I had given. Large heterogeneously enhancing area of consolidation with multiple cavitations within it. Largest with air fluid level in the right upper lobe. There were some ground glass opacities and multiple variable size soft tissue density nodules surrounding that area of consolidation, along with some interlobular septal thickening. Multiple homogeneously enhancing lymph nodes were seen within the mediastinum, suggesting mediastinal lymphadenopathy. So in a patient who has already completed her course of ATT and now has come for a follow-up after 1 year, what do you think we should give in the differentials for this particular picture? So it's basically a cavitating consolidation. So cavitating consolidation which is for 1 year and is not actually resolving with ATT, can think of drug resistant tuberculosis, and what else comes in your mind? Fungal infection definitely as a possibility should be considered. So another important thing that should be considered in the differentials is this is not the picture for this patient. So if on PNS CT scan, if we find a perforated nasal septum as well in this particular patient, this particular differential is also very important. You have to suspect. So Wegener's granulomatosis or granulomatosis with polyangiitis is actually a multi-system necrotizing non-caseating vasculitis which affects small to medium-sized arteries, capillaries, and veins with a predilection for respiratory system and kidneys. So classic triad is involvement of the lungs in 95% of the cases, upper respiratory tract and sinuses in 75 to 90% of the cases. It's better to get a CT-PNS also done in cases of suspected Wegener's, and also take a look at the kidneys on ultrasound because it is also involved in 80% of the cases. So any cavitating consolidation, you have to think of certain possibilities. If not tuberculosis, can think of possibility of fungal infection as well as Wegener's in our differentials for chronic cavitating consolidations. So coming to our next case, here we have a 25-year-old female who complains of cough and fever since the past 1 month now, and this is the HRCT done for this patient. Lung window axial section, where we can see multiple ground glass nodules that are seen in bilateral lung fields along with linear branching pattern. These multiple ground glass nodules that are seen along with linear branching pattern in bilateral lung fields diffusely. These are the coronal sections where again we can see this particular finding, ground glass nodules distributed in bilateral lung fields diffusely with linear branching pattern. This is the report that I had given, that multiple centrilobular ground glass nodules with linear branching pattern giving a tree in bud pattern was seen diffusely in bilateral lung fields with no evident consolidation or fibrosis that was seen. So based on this particular finding, the diagnosis that came to the mind was non-fibrotic hypersensitivity pneumonitis. So on probing and asking the patient further questions, she gave a history of staying in a place where there was a lot of construction work being done outside the house. So this was a case of non-fibrotic. So hypersensitivity pneumonitis represents a group of immune-mediated pulmonary disorders characterized by inflammatory and fibrotic reactions affecting the lung parenchyma and the small airways. The typical case of non-fibrotic hypersensitivity pneumonitis should at least have one abnormality in the parenchyma and the small airways. The parenchyma abnormalities include ground glass opacities and mosaic attenuation, while small airway abnormalities include ill-defined centrilobular nodules and air trapping in diffuse distribution. So coming to our next case, here we have a young 25-year-old male who presented with headache, and this is the MRI done for this patient. So these are the axial T1 weighted images where we can see one hypointense lesion in the high frontal paraphalcine region. These are the T2 weighted axial sections where we can see a heterogeneous lesion, heterogeneously hyperintense lesion in the right high frontal paraphalcine region. These are the FLAIR images where we can see minimal surrounding edema. These are the T1 post contrast images where we see this iso-intense lesion which is not enhancing on post contrast images. These are the T1 post contrast coronal sections where again we can see this well defined hypointense lesion which is not enhancing the post contrast images. So to get a better look at what the lesion is, I got a MRS done for this patient. So this is where we see a choline peak with a reduced NAA. There is no lipid lactate peak as such that is seen. And in normal brain parenchyma, we can see a normal NAA peak. So this is the report that I had given, an ill-defined intraaxial mass lesion which was seen in the right high frontal paraphalcine region, which appeared hypointense on T1, heterogeneously hyperintense on T2, and did not show any significant post-contrast enhancement. Mild surrounding edema was seen on FLAIR images with no evident restriction on DWI blooming on GRE. On MRS, particularly a choline peak with reduced NAA was seen in the mass lesion with no evident lipid lactate peak, which was suggestive of a low-grade glioma. So whenever you think of a possibility of a low-grade glioma, always get a MRS done, because this is a very important investigation as far as any tumor or neoplastic etiology of the brain is concerned, because it helps us differentiate between there is another case that I have presented on FCD, focal cortical dysplasia, where the MRS did not show a choline peak and it was actually a cortical thickening, and postictal edema was present in that particular patient. So this patient typically showed a neoplastic space occupying lesion along with a choline peak and reduced NAA. It was diagnosis of a low-grade glioma was given. Coming to our next case, which was actually an ultrasound case, a 12-year-old boy came with bilateral parotid swelling and fever along with pain in the right testis. And on examination, I saw that there was increased vascularity in the testis along with bulky epididymis, particularly in the tail region of the epididymis in the spermatic cord. There was increased in the echogenicity of the fat along with increased vascularity. So the diagnosis is pretty much very clear here. It's a case of epididymis. So epididymoorchitis, typical ultrasound findings include the tail region was most commonly affected initially, then it ascends to involve the body and later the head of the epididymis, and it's commonly associated with reactive hydrocele and scrotal wall thickening. On Doppler, typically an increase in PSV of more than 15 centimeters per second, and especially the PSV of the affected area is significantly higher than unaffected with a ratio of more than 1.7, and the RI is typically less than 0.5, which is seen along with bulky epididymis. So in such cases where you see bilateral parotid swelling along with epididymoarchitis, typically ask for a vaccination history. This patient did not take vaccines in the childhood. The parents did not believe in vaccination, and sadly such cases are coming a lot nowadays. I've seen 3 cases now in the past 1 week who presented the same complaints, bilateral parotid swelling along with epididymoarchitis. So coming to our next case, a 25-year-old male with breathing difficulty and backache. So this patient actually came for an MRI of the spine. I saw a mass lesion in the mediastinum and advised a CCT for this patient of the thorax. So this is the CCT axial section of the thorax, where we can see large lymph nodes in the axilla and the chest wall, a large mediastinal mass occupying the anterior and the middle mediastinum and also causing compression of the trachea and encasing all the large vessels. It's compression of the trachea and the collapse of the esophagus, large mediastinal mass. Lung window, we can see that there is collapse of the left lung with extensive pleural effusion. In the coronal sections, again we can see this craniocaudal extent of this mass lesion, which is homogeneously enhancing with multiple enlarged lymph nodes. So diagnosis is pretty clear here. It's a young male along with a large mediastinal mass that is seen, which is encasing the vessels, not infiltrating them, with multiple enlarged lymph nodes in the axilla and the chest wall, homogeneously enhancing mass. Large lobulated, this is a report I had given, large lobulated soft tissue mass occupying the anterior and the middle mediastinum, homogeneous post-contrast enhancement, compression and encasement of the aorta and the great vessels. There is compression of the trachea and the esophagus, and homogeneously enhancing enlarged lymph nodes in the mediastinum and the cervical region and the axilla and the infraclavicular region. So the diagnosis here is lymphoma. So lymphoma typically shows a homogeneous post-contrast enhancement, multiple enlarged lymph nodes, does not infiltrate the vessel, rather compresses them. So this was a typical case of a lymphoma which was diagnosed incidentally. So coming to our next case, here we have a 20-year-old male who came, he gives a history of trauma and now complains of pain in the right leg. So these patients usually give such history of trauma. So here we can see in the posterior aspect of the tibia and the mid diaphysis, there is extensive cortical thickening with a lucent nidus. There is some hyperdensity within the medullary cavity as well. So coming to the axial sections, where again we can see some subcutaneous edema along with a cortical thickening in the posterior aspect of the tibia with a lucent nidus and some hyperdensity within the medullary cavity that is seen, which is indicative of edema. Very well seen lucent nidus and cortical thickening. The diagnosis is very clear here. It's a spotter. So this is a report that I had given. A small osteolytic lesion. Typically, it measured 2.7 mm. The osteolytic lesion within the cortical thickening measured 2.7. So it's important to give the size of that lytic lesion within the cortical thickening, because more than 2 centimeter usually is indicative of osteoblastoma, which is a differential for this particular condition. So cortical thickening in the posterior aspect of the tibia and the mid diaphysis was seen, accompanied by adjacent cortical hyperostosis and increased density of the medullary canal, which was suggestive of marrow edema. There was no cortical destruction and extraosseous soft tissue extension, which is very important to rule out any malignant cause of this particular condition. There was mild subcutaneous edema. Features were suggestive of an osteoid osteoma. So that nidus is actually responsible for prostaglandin. So this is a very simple diagnosis and a very it's a spotter case, so it should not be missed. Even if the patient provides a history of trauma or such cases, most of the bone tumors, they will give history of trauma, but The important thing is the findings are to be seen and reported. So this is an important sign of osteoid osteoma on MRI. It's called a half moon sign. This particular edema, marrow edema, looks like a half moon. So hence it's given this particular, so this particularly seen in the osteoid osteoma of the neck of the femur. It is not very specific sign. It can also be seen in case of stress fractures, but it's a good sign to be remembered, that if this patient comes for an MRI and you see this particular thing, you can get a CT done to see if there is some cortical thickening. Another important sign to be remembered in osteoid osteoma is double density sign in case of a bone scan, where we can see that there is a hot spot within a hotter spot that is seen. This particular right greater trochanter. So it refers to a central focus of increased uptake within a surrounding lower but nonetheless increased uptake rib. So coming to our next case, so here we have a 40-year-old female who complains of pain in the ankle since the past 3 months now, and this is a CT scan done for this patient where we can see a lytic lesion in the talus adjacent to the tibiotalar joint. This lytic lesion, well-defined lytic lesion is seen. There is no degenerative changes as such within the joint. This is the MRI done for this patient. These are T1 weighted images which is appearing hypointense, hyperintense on T2 weighted images. And this is the fluid sensitive sequence where we don't see any evident surrounding edema. And there is no degenerative changes as such which is seen in the joint. So it's a spotter case. It was a case of intraosseous ganglion cysts, which are actually benign tumor-like non-neoplastic lesions which occur in the subchondral regions of the bone. In the absence of any degenerative or inflammatory arthritis, intraosseous ganglia are cystic, well-defined lesions which are located close to the joints, and they have similar imaging features as subchondral cysts, except that there is no degenerative change of the joint. So they typically look like a unicameral bone cyst, but simple bone cyst usually occurs in a very young age, and this is a 40-year-old female, and adjacent to the joint only it was seen. This might show signs of cortical expansion, thinning, and articular or non-articular cortical defect is very common. Periosteal reaction should not be present typically. It can be confused for a subchondral cyst if the degenerative changes are present within the joint. But in our case, there was no degenerative changes in the joint, so it was a case of intraosseous ganglion cyst. So our next case is a case of a Doppler. 60-year-old male came with swelling in the left leg below the knee, and a venous Doppler was advised for this patient. This is the swelling that was seen. And this is, I'm tracing the GSV from the medial aspect of the ankle where you can see this incompetent perforator. A dilated GSV is seen with multiple varicosities arising from it. And as I go near this particular area just below the knee, we can see that this was not taking color also, and echogenic filling defects was seen. This was not compressible. Extensively dilated echogenic filling defects, non-compressible superficial varicosities, suggestive of a thrombosed superficial varicose veins. So the GSV was also incompetent, and there was also perforator incompetence at places. Multiple dilated tubular anechoic superficial and deep subcutaneous vascular structures arising from relatively engorged great saphenous vein, the left medial ankle, medial leg, and the thigh was seen. Dilated veins, the medial aspect of the leg just below the knee showed echogenic filling defects with no evident vascularity on Doppler, suggestive of thrombosed superficial veins. So this is also important that we have to remember certain complications of long-standing varicose veins, which include ulcerations, thrombophlebitis, and thrombosis of the superficial veins, and even deep vein thrombosis. So luckily here the deep veins were normal. So here we have an interesting case of an 18-year-old female with pain abdomen, where the probe is kept in the right hypochondrium, where in the GB fossa we can see on ultrasound that linear echogenicity along with posterior acoustic shadowing is seen, a typical wall echo shadow sign, suggestive of cholelithiasis with a contracted gallbladder. So a diagnosis of cholelithiasis will be given in this case, but in any case of cholelithiasis, we have to remember it can present as discrete echogenic calculi within the lumen of the gallbladder, which can be measured separately, or as a wall echo shadow sign. A common habit which I've seen among the patients is to ask for the size of the calculus. That kitna bada pathri hai Dr. Saab, or whether it can be treated medically or surgically. So any case of cholelithiasis cannot be treated medically. Ursodeoxycholic acid does not have a proven benefit in cases of gallstones. So medical treatment is of no use, but still this question patients will go on asking as to how big the calculus is, and in this case, that this presentation of cholelithiasis, that is wall echo shadow sign, it is very difficult to determine the size of the calculus or calculi, because we can't even say whether it is a single large calculus or multiple tiny calculi giving such appearance. So I had given it as cholelithiasis and advised a MRCP for further evaluation. So the patient was very keen on knowing the size of the calculi. So wall echo shadow sign is a ultrasound sign which is seen in the GB fossa, which refers to curvilinear hyperechoic line representing the wall, thin hypoechoic space representing small amount of bile, and curvilinear hyperechoic line representing the near surface of the gallstone and acoustic shadowing. The sign suggests a large gallstone or multiple small gallstones filling the lumen of contracted or incompletely visualized gallbladder. So finally, an MRCP was done for this patient, and this is the MRCP of this patient, and it was done after a lot of efforts, that is taking very thin sections through the abdomen, multiple tiny T2 intermediate filling defects in the GB lumen as well as the cystic duct, along with sludge was seen. The CBD and the IHBR were all of normal diameter. These are the axial sections, these are thin sections. Again, it is not seen very well here. So a lot of effort was put into getting that thin section of the GB in this case. And finally, the diagnosis of cholelithiasis was confirmed along with the size of the calculi. So in such cases where the patient insists on knowing the size of the calculi, or the doctor insists on knowing the size of the calculi, he can always order a MRCP for this patient and be doubly sure before operating on the gallbladder. So here is another interesting case of a 40-year-old male who came with a right element type of facial palsy, and an MRI was ordered for this patient, and here's the MRI picture. So any case of facial palsy or neuropathy, important sequence is a CIS sequence. In my machine it's called the Fiesta sequence. So to look at the nerves, it's very important to get this sequence done. So this is the Fiesta sequence, where we have to know the anatomy of the cranial nerves very well. This is the fifth cranial nerve that is seen, the Meckel's cave, and this is the seventh and the eighth cranial nerve. This is the sixth cranial nerve, abducens nerve. This is the seventh nerve, which is traced up till the geniculate ganglion. So on non-contrast images, hardly any thing is appreciated in case of Bell's palsy. So always try to get a post-contrast image. So on post-contrast image, it looked like this. So if we can see properly, we can see some asymmetric enhancement on the right side in the internal, like just before the geniculate ganglion, the internal acoustic canal. It is seen that right facial nerve is enhancing asymmetrically. So upper motor neuron type of facial palsy usually involves lower half of the face, while lower motor neuron type of facial palsy, that is after the facial nucleus, it usually involves the entire face, entire half of the face. So coming to Bell's palsy, usually lower motor neuron type of facial palsy, that is after the facial nerve nucleus. Uh, on MRI, long segments of the facial nerve enhance in a uniformly linear fashion more intensely than the contralateral non-affected side. However, the enhancement of the nerve is not seen in all patients and reportedly variably between 57 to 100%. It is also essential to appreciate the normal pattern of facial nerve enhancement cases. The facial nerve on either side of the geniculate ganglion is the most commonly involved. From the distal internal auditory canal to the distal tympanic segment. So this is very important that in our case also distal internal auditory canal area was typically involved. The mastoid and the extratemporal segments are less frequently involved, and importantly the nodularity should raise the suspicion of a neoplastic cause, and a careful search for remote areas of leptomeningeal enhancement is performed in such cases. Look for any tumor. So this is also an interesting case where a cis or fiesta sequence is a very important sequence. It helps us to diagnose case of Bell's palsy and also any associated tumor.